Hello, and welcome to the Alabama Public Health Training Network. I'm Bill Kennedy with the Alabama Department of Public Health. Thank you for joining us today for our program, Intersection of Stigma and Fear, Living with HIV in the Age of COVID-19. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on our screen now and will appear again later in the program. Also, the handouts and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching it on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today, James L. Sacco. Jim, as we know him, is a consultant to the Department of Public Health and has been with us many a times. This actually is our third presentation training that we've done in this COVID-19 age. And so we look forward to hearing what Jim has to say. So welcome, Jim. I know you have a lot of important information to cover today. So let's go ahead and get started with your presentation.
Well, Bill, thank you. It's a pleasure to be here. For those of you just joining the conversation, as Bill said, this is the third of four COVID-specific trainings that we're doing over the course of June and July. As I work with the planning committee, what we heard is there's a whole lot of reaction to the pandemic flu and concern about how to respond to unique needs that have emerged. And so what we've done is we've broken this into a series of meetings. The first special population we dealt with is older adults. And obviously, as we look at who's being impacted by COVID-19, the impact of older adults and some of the unique psychosocial stressors for older adults is enormous. 2 weeks ago, we looked at the needs of individuals with substance use disorder and opiate use disorder. And again, what we're trying to do is sort of put the COVID pandemic in the context of what unique needs exist for certain populations. Our third workshop today is designed to think about the needs of individuals living with HIV and by default, those of us who care about people living with HIV. And so what we'll do is start with a quick COVID update, talk a bit about the psychosocial stressors, some of the medical facts about living with HIV in this age, and then some biomedical intervention and a whole lot of psychosocial intervention, things we can do to promote health in the lives of people living with HIV. So there's our goal. We're going to explore and increase our understanding of the needs of individuals and how to respond. Those are objectives for this web training. We're going to look at some unique stressors for people living with HIV, and we're going to talk a lot today about stigma. The title of the workshop is deliberate: Stigma and Fear, and sort of thinking about the impact of stigma, particularly through the lens of people who've experienced previous stigma and the psychosocial reactions that come along with experiencing stigma, including issues of healthcare and health seeking. And then the second part of the title, the fear around COVID-19 and sort of addressing some of the psychosocial needs of people living with HIV. Fear, grief, sadness, isolation, things that many of us are dealing with, but because of some of the pre-existing conditions related to living with HIV, some unique intervention approaches. As Bill said, I've scheduled several times in the talk to take questions, and so you've got a chance on Facebook Live, and I'll show the email address. I really miss classroom teaching. I really miss being in a classroom with a box of donuts and real live people and a chance to have a conversation. So I really welcome people's input, questions, and comments. As I said, there'll be several times during the presentation where I stop and say to Bill, what are we hearing on Facebook Live, or what are we hearing via the Alabama Public Health Training Network website. So with that, I'm going to do a very brief surveillance update. These data are July 1. In order to get this slide deck cleared and finished, I had to stop early. The surveillance update is bad. There's no other way to say it. There's only, as far as I can tell, there's really only bad news to report on the surveillance update. Today is actually the day. Today is actually the day that we will cross the threshold of 3 million cases of COVID in the United States. It appears, if we stay on track, today will be the day that the 3 millionth American with COVID-19 is diagnosed. We are averaging about 50,000 new cases a day now. That number has consistently gone up since mid-late May, and again, the average is just about 50,000 new cases. I looked at Alabama surveillance this morning. Alabama is not growing as fast as it was, but the bad news in Alabama is there over the last 10 days or so, there's a consistent average of about 1,000 new Alabamians every day who are being diagnosed with COVID-19. There's about 1,000 new cases every day in Alabama. And again, that trend has gone up since late May. And I just looked at this morning, I just looked at the last 10 days data. And while there's variability, including the last 10 days, there have been 2 days where Alabama had more than 1,700 daily cases of COVID-19. All that to say, our work in terms of primary prevention of COVID-19 is absolutely critical. Now, we've had about 130,000 Americans die, and on June 30th, again, I just took a snapshot of July 1, 560 Americans died of COVID-19. If you've read the news at all, you know that the South and Southwest are having an explosion. Most people list Florida, Georgia, Arizona, and Texas as the most problematic 4 states. These others continue experiencing growing rates of COVID-19, and good news, lower case rates in some states, particularly states that have hit harder and longer on stay-at-home orders. The reality of this pandemic seems to be clear that opening too early has been associated with increasing case rates. There's another argument about the economics of COVID. Merely from a disease surveillance perspective, what we see is higher case rates accompanying states that have opened early, fewer restrictions on staying at home, and tend to follow places which are more lax in terms of mask use, mandating mask use. Again, the summary here, increased opening up has resulted in increasing cases. We've got people backtracking on opening up. Florida, Texas, California all rewound. They're opening up. They locked down beaches for the 4th of July all over the country. Again, I know that Texas, California, Florida closed all major beaches, and so sort of I think of it as the gas pedal and the clutch, how to open up safely to support business, and how to do that in a way that's safe. And again, there's an argument, I think, particularly people looking at Texas, Florida, Arizona as places that probably opened too soon, weren't as strict in infection control precautions and surveillance. All 3 of those places now have general population surveillance over 1%. I saw a study early this week that said statewide prevalence of COVID-19 in Arizona is 3%. of the population in Arizona test positive. The global expansion continues to look much the same as it has been. Brazil, unfortunately, leading the way in terms of new cases. Big news since the last meeting, big news this week. The president of Brazil has tested positive and apparently is symptomatic for COVID-19 after being an early denier of the seriousness and someone who sort of openly said he didn't believe in it and didn't believe in precautions. But probably the hardest hit country, again, those tend to be in terms of global case increases. There's increasing global public health concern about COVID-19 in Africa. There's currently about 500,000 diagnosed COVID-19 cases in the African continent. Most people believe that's an underreport, and because of the poor public health infrastructure, all kinds of concerns about just the general state of public health in many countries in Africa. There's growing concern that the next wave, if I'm here in 2 weeks or 4 weeks, we'll be talking about Nigeria, other countries in sub-Saharan Africa, Nigeria being the most populous, likely the most vulnerable, as I understand surveillance. The other thing to talk about, and I'm not an expert on politics, so I'll just defer to another webinar, but there's a deep politicization of the issues around COVID-19. Opening up or not opening up has become a political issue. Wearing masks or not wearing masks seems to be a political issue associated with one party or the other. I think it's unfortunate that politics instead of science is guiding our response. Again, particularly as you see sort of the global graphs. I suspect most of us have seen global graphs of European countries, Asian countries, where their COVID-19 pandemic dipped and now are staying. Our curve, as it were, has just gone in the opposite direction. So we've got a public health crisis, and my belief is there's a public health response, and science ought to dictate our response. But that's not where we are, and I don't see resolving the political divide anytime soon, and I don't have the answer. Just want to name the fact that I think most scientists believe COVID-19 prevention and treatment are science issues and to be answered with scientific and not political decisions. The last thing I've talked about in the previous webinars, but I'll just name, is the enormous increase in behavioral health concern around the pandemic, issues of isolation, a kind of collective grief. I've taken as saying that maybe we should start to conceptualize COVID-19 as a kind of natural disaster with the predictable traumatic effects of trauma that we would see in an ongoing natural disaster. There's pieces of data, lots of anecdotal reports of increasing cases of depression, anxiety disorder coming from the mental health community. I also read a report last week that talked about increasing national overdoses over the months. April overdoses were, I think, 30% higher than March, another 30% or 40% in both May. I'm sorry, from March to April and April to May. I don't have June data yet, but my concern given that trend is the increase in drug overdoses, likely associated with people being in isolation. What we know about overdose is that where injection drug users are injecting, there's often someone available to assist in the case of an overdose. As people are socially distancing or being more isolated in their drug use, my hunch is that a piece of the overdose puzzle is that people are overdosing at similar rates, but without access to overdose referral by my friend. I'm not surviving what could have been a survivable overdose. I do volunteer work at a syringe exchange here in Asheville, and what I hear regularly as people get Narcan is that they're using it among their fellow injectors, and that tends to be a pretty normal part of the milieu. So that's my very brief update. Again, I don't mean for this to turn into a surveillance talk. It just does seem, since we're having these biweekly conversations, some kind of update makes sense to kind of put the psychosocial remarks, the population-specific remarks in a context. Now, I said earlier, questions and comments, that's the email address that we'll be monitoring over the course of this, as well as Bill says we've got questions that will come on Facebook Live. Bill, anything right now that I should address before I move into the content of the talk?
No, Jim, I think everything is going good so far. So thank you.
Great. All right. As I said, if you've got questions or want to make comment, please take advantage of the website or go ahead and Facebook Live and send those questions. So I want to start with the medical facts, and I want to start with the good news. Since I've started us off on such a grim note, it seems like I might as well go ahead and include some grim news. The excellent news in terms of people living with HIV, and again, obviously, as the epidemic began, we sort of, everybody concerned about what about people with underlying immune disorder, and were they more vulnerable, and what specifically for people living with HIV. The great news, and this is pretty much consensus in the HIV treatment world, is if people are virally suppressed, that is, if they're well-controlled HIV, there's no higher rates of contracting COVID-19, and survival rates are at least as good as the general population. In preparing for this, there's studies out of a small study out of China, fairly large study out of Spain, another study somewhere in the EU, I want to say Netherlands or somewhere in Northern Europe, but just sort of looks at survival rates. And generally, again, they look at, okay, here's a cohort of HIV positive people. How are their survival rates, and how do those compare to the general population? Again, where people are well managed with their HIV, there's at least as good a survival rate as the general population. What's curious, and this is being questioned, I'm just going to put this out on a Post-it note as something that's being studied. As I looked at those studies to prepare for this talk, there's also some conversation about whether or not the antiretrovirals that people living with HIV are taking may actually have some protective value, may actually prevent COVID-19 among some individuals. This is bench science, still in the laboratory. There's no possible way the FDA is going to say take X drug, take X HIV drug to prevent COVID-19 acquisition. But there, as I said, are some early lab studies that are pointing to a possibility, who knows, but that maybe some of the drugs currently used to treat HIV could in fact be deployed to mitigate COVID-19. What's troubling about the data is that not only are people who aren't virally suppressed, that is where there's still virus activity, and whose CD4 count is below 200, normal range in healthy adults is about 1,000 on that lab marker, are at higher risk for mortality. So the takeaway here is HIV patients who are virally suppressed are in good shape to weather this storm. Those individuals who are not in care, who are not taking their medicine as prescribed, whose immune system functioning is not good as measured by their CD4 count, are at increased vulnerability for death as a result of COVID-19. The challenge to us is about 40% of people who've been diagnosed with HIV are not yet virally suppressed. Those of you working in the field, this is not a surprise to you, but what we know is of those people who've taken HIV positive, taken an HIV test, about 85% show up at a care appointment. We lose some people along the way. And then of those who are enrolled in care, a big chunk fall out of care. Some studies at 60–65% of those individuals are retained in care, and of those individuals, another percentage are not virally suppressed. This is concerning because if we talk about the fact that people knew their status, somehow got to care and or started HIV care, but have fallen through the cracks, these individuals and the risk, this means there are hundreds of thousands of Americans at risk for COVID-19 because of their poorly managed HIV. Maybe who are not in care. I think there's a challenge to the public health system. There's certainly a challenge to people at the clinic level. How do we reach out to people who've fallen out of care, people who aren't virally suppressed, and convey the benefit not only in terms of HIV management, but the added benefit of COVID-19 management. The last reminder down there is, as we talk about people living with HIV, the great news is a whole lot of people who are living with HIV are living longer. The people in the treatment world want us to know this is not necessarily a death sentence anymore, and that we've got people living longer and living well with the virus. And nearly half of people in this country with HIV are over 50. The trade-off is that increasing age is a risk for not contracting the virus, but risk COVID-19, but risk for severity of disease. What you would have seen if you were with the talk last week is 80% of fatalities happen with people over 65. And so again, if you look at the age data, fatality for COVID at 50 and 60 and 70. I think it's important that we tell these young people who are out honky-tonking and out partying as if it's no big deal, that we certainly have cases of people who've died from COVID in their 20s and 30s, healthy, functioning young people who have contracted and died. But the reality in terms of lethality is that age is definitely a risk factor for mortality. Rhonda Holland with the Wise Woman program has asked me to specifically reiterate that 50 is not old age, and that we shouldn't think of calling people over 50 old. And she is a sponsor for this and has made sure that I said people over 50 are not old. Reminder about COVID transmission. It continues to be spread by respiratory droplets, coughs, and sneezes. There's increasing conversation about lingering particles in the air, the particulates that aren't just a sneeze or a cough. Obviously, mask wearing is the most critical step we can take, but this idea of particles lingering longer than we thought in the air. No one has the science of how long, how intense, but there's increasing conversation among virologists that we might not just be talking about my coughing or sneezing, but the idea that particulates in the air live on and have the potential for infection. Virus gets in the body through your eyes, nose, and mouth, travel deep in the lungs, and then the immune response is out of control. This is important. Pneumonia, severe lung disease. This is important because one of the things that's emerging in terms of the clinical picture for COVID, a lot of us hoped, this is like a flu at first, and then it became, no, this is really, really serious respiratory disease. And increasingly, there's a conversation among clinicians that there are long-lasting medical complications, again, long-lasting respiratory complications of having COVID-19. And I think as the clinical picture emerges, I mean, we're really talking about 90 days, maybe 120 days of clinical care. We're just at the tip of the iceberg in terms of understanding the long-lasting effect of COVID-19 infection. But I think most people are starting to think that this longer organ damage, this longer state to return from normal may be something that we're going to continue to see. Messages for people with HIV, messages for all of us. These are the reasons to get to the emergency room. These are the symptoms of respiratory distress. Shortness of breath is the most important factor. And these other signs of respiratory distress, do not pass go. Get yourself to the emergency room. immediately. If you've got underlying COPD, other underlying respiratory disease, this last reminder is that if in dealing with previous COPD, your outbreak is similar and you didn't go to the ER, you dealt with your primary care, used some other breathing treatments. Again, if your current symptoms wouldn't have had you go into the ER, it's probably best to not go to the ER, to work with your primary care provider to find what's right for you. If you've not had underlying respiratory disease, serious respiratory disease, and experience these symptoms, the advice is get to the emergency room. These are signs of significant respiratory distress. What do we do to not get HIV? Of course, this good news, this language has not changed. Hand washing, physical distance, masks in public, self-isolation when you might have been exposed. I have a friend who went to a social occasion. They were protected. Some other people weren't. There's some discussion that somebody at this birthday party had COVID, and so my friends, out of I think good sense, out of an abundance of precaution, have gone back to stay at home. And it's a single female. She's self-isolated. She is at home, groceries being delivered, no contact with anybody for 14 days. And so part of the way we break the curve are these good measures. This last reminder comes from HRSA HIV website that I was looking at to get ready for this talk. And what they remind people living with HIV is remember to include healthy lifestyle choices, good eating, exercise, good health practices, good sleep hygiene. Again, the basics of being healthy: eat right, get some physical activity, drink water, get enough sleep. That reminder. So probably for all of us, but it was interesting as I looked at the HRSA HIV website. They specifically gave some guidance to people with HIV. Again, our updates for HIV are sort of prevention messages for people who are living with HIV as we open up. The virus has not gone away. COVID-19 is still here. Particularly if you are someone who not in care, you don't know your viral status, your virus is not well managed, you need to be especially careful. The takeaway from this meeting should be that finding those people who aren't in care and virally suppressed is essential, and the consequences of having HIV that's not well managed are particularly grim in the age of COVID-19. And then good infection control practices. This last reminder here is about re-engagement in care, and a shout out to my HIV case managers and my HIV care providers monitoring that viral load, aggressively reaching out to people that have fallen out of care, being especially aggressive with that HIV treatment when someone isn't virally suppressed. And people living with HIV are people that love HIV people. This message to find support, whatever support you need, and get back into HIV care is a critical message, and one that has the potential to save lives. Bill, let me do a quick check-in. Any questions that have come in that I should address before I start with the psychosocial issues?
Jim, well, no questions yet, but I have one. I know as this epidemic continues, we're continuing to see a lot of our public health workers being pulled to do contact tracing and investigations and things like that related to the COVID. And as you talked about the number of folks that don't know that they are positive, HIV positive, and trying to find those individuals and reaching out to them. Are you seeing that same difficulty in North Carolina as well?
Absolutely, Bill. Thank you. Yeah, I think it's everywhere. We're balancing which fire to put out first. You and I were talking, right? So we ought to be. We've had DIS in North Carolina. whose job was to go out and notify people of disease. Some of those people have been also going out and inviting people back into care, so that most states now have what's called a data to care program. Clinics merge their data with health department data and identify patients who've fallen out of care. The DIS had been following up. In many cases, DIS, it depends on the program. In many cases, those individuals were going out and tracking patients. You're right. In the age of COVID-19, the burden on partner contact for COVID-19 is enormous. You and I were also talking before we started about outbreaks of hepatitis, other STIs. I think in most places, public health is just stretched as thin as it could be stretched because of the political pressure and disease burden. I think most places are erring on the side of let's track and find COVID, which certainly makes sense. On the other hand, if I'm an HIV clinic and I know that I've lost a few in the cases of clinics in Birmingham, Mobile, Montgomery, I'm guessing they could list 100 or a couple hundred people that they've seen over the last few years who disappeared. There's several hundred, probably 1,000 Alabamians with HIV, poorly controlled, and extraordinary risk to contract and die from COVID-19. I don't have the answer, but the tension is exactly right. Like everything in public health, we are tracking lean resources. And again, I think in North Carolina, as in Alabama, the pressure is, and with good reason, to track and respond to COVID-19 cases because of the emergent need in North Carolina and Alabama because of the continued growth of cases. I mean, we're talked about case rates in Alabama. We're not bragging here in North Carolina at all. Full disclosure, we are having a curve very similar to most of our southeastern neighbors, where we're not Florida or Texas, but we are going the wrong direction in North Carolina and have been for the last month or so. One of the things that was in the title that I think is really important is as we think about responding to COVID and the needs of people living with HIV, that we think of the impact of stigma. And in this case, I really start with the idea of historical stigma. I have a buddy that phoned me early in the epidemic. I've been involved in HIV prevention and care for more than 30 years now. And I have a buddy who was also one of the early social work people in Atlanta, where I lived at the time. And kind of out of the blue in late March, he phoned me and he said, "Man, I'm having some flashbacks to the early days of HIV and who's got it and who doesn't have it, and can I catch it, and do I take a test, and who's going to know the results of my test." I hadn't put the pieces together, but I thought, yeah, there really is some parallel in terms of this infectious agent kind of coming out of nowhere, not 100% sure, a stigma of having it, fear of contagion that feels really important to name, and in terms of responding to the needs of people with HIV predisposes people with HIV, I think, to these negative impacts of stigma. So there's a definition from a sociologist. I think this guy's in Berkeley sociology. Underlying undesirable attributes, lower social values, things that cause us to experience, and again, race, ethnicity, gender, sexual orientation, substance use, other reasons why people have felt stigmatized historically. These quotes are taken from a program that I did sometime early in the spring with another organization, specifically targeted to people living with HIV. And what these were from the evaluation data. And as part of the talk, we just kind of said, give us your thoughts, and these are some things that long-term survivors, that is people who've lived with HIV, in most cases 10 or more years, many people 10, 20 years. But the quotes here, starting to encounter PTSD-like feelings like the trauma I experienced in my diagnosis? What about I've got HIV and COVID-19? And what about issues of stigma? The last reminder here, again, somebody with COVID and living with HIV uses the phrase, it's double the stigma. And again, I would argue that for people living with HIV, these early targets of stigma, the sort of existing prejudice and discrimination that people have experienced in their lives, perhaps, makes their challenge of living through COVID, again, is perceived as flawed. Additional issues, let's kind of overlay issues of COVID. I need to name, I think it's really important, that there's been a stigma, I cringe to even say this in America, but there's been a stigma associated for Asians and Asian Americans as a result of COVID-19. People talking about a Chinese virus or a virus from China. I have a buddy in Tennessee, outside Nashville, who is as Middle Tennessee as they come, who is a biscuits and gravy, Grand Ole Opry kind of Tennessean, born in Tennessee, and happens to be Korean American. And he's shared on Facebook multiple different instances of strangers staring and rolling their eyes and pointing and glaring, sometimes while his 11-year-old, also Asian American kid is nearby, because of a perception that the problem of COVID-19 is related to this guy in the grocery store who's a Korean American Tennessean who's lived here his whole life. But again, just to name the issues that come up, there's a big bunch of, well, this is a big city problem. As long as we don't go to California or New York City, we won't have a problem. And so sort of as people decided what to be wary about, some people decided that urban Americans. What's enormously important to name, and could do a whole other workshop, is the impact of people of color who contract COVID and their poor health outcomes for Latino Americans, for African Americans, and grave concern that COVID-19 not only is affecting this stigmatized population, but a reminder to us that we're not in any way addressing all of the social determinants of health. And as with many other serious illnesses, COVID-19 sort of shines a lens on that problem. Other issues of stigma, essential workers who have to keep coming back to work, again, frontline responders, but the people that are there at my convenience store, at my gas station, people who are working at Target, wherever else, because we need toilet paper and mouthwash. The idea that there's some sort of subtle stigma, judgment, because of people who have to continue to work. And then again, are there issues of who got money and doesn't have money, who's on unemployment, just the nuance of ways in which not only having COVID-19 as an issue of stigma, but some of these other variables have shown their head in terms of prejudice, discrimination, eye rolling. And then again, as I quoted my friend Dave earlier, flashbacks for some of us to early days of HIV. When patients have experienced stigma, this is a kind of negative self-talk that can come up. And so as we try to think about the psychosocial needs of people who survive stigma, it's really essential that we name these negative beliefs, thought patterns, and try to work with patients to identify. What you should see is these are also going to impact the possibility of doing COVID-19 prevention, response, and make it in the way of individual self-care. Sam Logie at the University of California, San Francisco talks about the intersection of people who have HIV and other aspects of their identity. What the term he coins is intersectional stigma. That is, I'm living with HIV, but which is clearly a disease with extraordinary stigma, but because of these other pre-existing sources of prejudice and discrimination, I may experience the intersectional stigma. And so what happens if I am someone who's experienced prejudice, discrimination, eye rolling, develop those patterns or beliefs about myself? I may be, as I come to healthcare, I may be overly sensitive. If I feel judgment internally or I felt judged other places, I may be someone who comes in with my radar up, wondering if this is a healthcare interaction where I'm going to be judged or shamed or blame. Also, what we certainly know is that when people have experienced stigma, there's a disproportionate amount of mental health substance use challenges. I talked earlier about that HIV care continuum is the language they use. Who's been tested, who falls out of it, who goes to care, who stays in care. I've said all along that as I think about who doesn't show up for their first meeting at a clinic, who doesn't stay in HIV care, who's harder to virally suppress, that mental health substance use problems must be part of those people who are harder to retain in care. And it's not that I'm a genius. I've just talked to literally hundreds of medical social workers in a variety of HIV care settings over the last 30 years. And they say the people that are hardest to keep in care are young people, women, and people with behavioral health problems. Those are patients who will need additional support in order to be sustained in HIV care. Again, a disproportionate number of people who've experienced stigma also have a history of trauma. And so issues about authority and bossiness. And if the systems aren't aware, there's a study at Duke. I was part of the rollout of the study. I didn't do the research, but I did some training afterwards. A woman at Duke found that in a study of a couple thousand HIV patients in the Southeast, that 40% of the female patients in the study reported at least one adverse traumatic event in their adult lives, child or adult lives, and about 30% of male patients. And so what we probably see in HIV care settings is a disproportionate number of people who are living with traumatic histories and, again, the need for trauma-informed approaches. So what do we do in terms of supporting people living with HIV? I think to just normalize the stressors that we're all experiencing. Anxiety, stress, again, what I'm just saying automatically is anxiety, stress, grief, issues of trauma, anxiety, checking of symptoms. I've had some kind of scratchy throat on and off for months, and it's not COVID-19, but I have it. It's not serious. Normally, I wouldn't probably even notice, but you go, oh my gosh, that's a scratchy throat. Where have I been? You know, and so this over involvement with symptoms, becoming irritable, feeling unsettled. I've had some cognitive difficulty, and I think others report that. I was in conversation with a mental health therapist early in the COVID-19 epidemic, and she said, you know, there's a lot of people who are experiencing kind of free-floating grief, and that difficulty with cognitive processing can be a symptom of grief. And I've started to wonder for myself and others if just the sadness, some of these emotional reactions, hopelessness, lack of control, difficulty, concentration, if all of these might not be a subset of a kind of free-floating grief. Our models of grief don't include a pandemic virus that affects 3 million Americans, that kills 130 Americans. And so I don't know that we've got models for how to normalize what we're all experiencing. My sense is we're all just doing the best we can and finding our way as we go in terms of providing the psychosocial support that many patients need, and again, maybe some of the unique support that people with HIV. So I think some messages that are important to people living with HIV is to normalize the fear, to say fear of contracting COVID-19 is a normal reaction to this. I also think, given what I've been hearing, not just from my friend Dave or those quotes from consumers in that previous evaluation, but I think it's important to say there may be some flashback to early HIV, and that doesn't necessarily mean response to the 80s. I think issues of stigma are associated with the diagnosis of HIV. So whether someone was diagnosed with HIV in the 80s or the 90s or the 2000s, those issues of shame and guilt and blame and contagion, all the junk that most people living with HIV have lived through, may be there in the shadows, maybe things that we're re-experiencing. I find some reassurance in thinking that maybe most of us are not going to contract COVID-19, and that the fatality rates continue to be fairly low. That there's an error on that slide that's important. It is less than 3%. The risk of dying is less than 3%. Sorry for that error. That's important. Steps we can take are common knowledge, and we all deserve protecting. Thoughts here about grief that I've I think shared some of this 2 weeks ago, but this whole idea, just starting to explore the idea of a collective grief. And what we know about grief is allowing the feelings, allowing the tears, and recognizing that the course of grief is not predictable. I find when I talk to people, how you doing today? Monday, I may be fine. Tuesday may be a different story. Again, for me, depending on how I'm doing in terms of my self-care, how much news I'm taking in, all of those variables kind of come together, and my mood has been kind of a roller coaster. And again, I think the idea that I'm in a unique, unpredictable pattern is something that many people that I care about and people that I've talked to have mentioned. The reminder in terms of responding to grief there at the bottom seems enormous. Being gentle with yourself, and for all of us, whether your consumers are living with HIV or not, whether we are living with HIV or not, practicing good self-care in the age of COVID-19 is essential. I'll put a little plug in for our next webinar a couple of weeks. The fourth in this series will be about self-care for all of us. When we think about who's survived trauma and stigma, these kinds of messages are messages of resilience in light of pre-existing trauma and the experience of stigma. As part of the trauma conversation, there are a number of researchers who look at factors related to resilience. That is, who are the people who experience a traumatic event but who don't go on to develop lasting symptoms, and issues of adaptability and optimism and humor and ability to cope and resilience, that is bouncing back after hardship, are all factors that seem to be related to resiliency from trauma. That is factors of people who don't have lasting negative psychosocial impact following the trauma. Again, this last set here, same set of questions from some clinicians at Duke who do this work on trauma and resilience. I can achieve my goals. I'm not discouraged by failure. My view of myself is as a strong person, and I can handle difficult emotions. These 10 factors are all demonstrated to be factors associated with resiliency. I include those here because if you are working with people who've experienced trauma, who've experienced a negative impact of stigma, it seems really important that we look at these factors associated with resilience, and we ask ourselves as helpers, how do we help foster these traits among people that we're working with? So a lot of background on psychosocial and recommendation. I'm going to take a drink and ask Bill, are there any comment or questions that have emerged so far, Bill?
Hey, Jim. Yes, we do have a couple of comments that have come in and/or questions. Let me start with the first one. It kind of goes back to the earlier part of the conversation, and it talks about complications with individuals with HIV and AIDS having pneumonia or even tuberculosis, TB. Have you seen any studies that have any correlation with AIDS causing an increase with pneumonia related to COVID? You talked a little bit about the antivirals, but maybe those that aren't taking the medications regularly. Are you seeing any studies related to that?
Yeah. Bill, I don't have the answer. What I'm thinking about is with people who have advanced disease, who've had multiple respiratory problems and where there's sort of lasting respiratory vulnerability, it does seem like if COVID was acquired, it does seem like there might be an increased likelihood. What I'm also thinking is those people are likely older and likely more vulnerable. I think that I don't know that there's something intuitive that says, again, if a patient has underlying COPD, that underlying respiratory condition makes the disease severity that much worse. I think what I would reiterate is for people living with HIV, the key variable about COVID-19 acquisition is whether or not my virus is well managed. And again, if my virus is well managed and I'm doing the normal sort of the routine infection control things that are suggested, the likelihood of acquiring COVID-19 is same or less than the general population. Bill, you're on mute. It seems like you want a question.
Thank you. The second comment just compares when HIV was first identified back in the 80s and how there was just a lot of unknown about the disease and about the virus and how similar that is to what's going on now with COVID. There's a lot of unknown that's related to COVID. And so individuals, folks back in that time, did everything they could to kind of protect themselves from the virus, and you're seeing that again now. Some maybe overly protecting themselves, but just that fear and the unknown. Any thoughts there? Yeah, no, I think that's enormous, Bill. Thank you. The medical parallels are there. Again, we've got a virus that's new and scary, that's potentially life-threatening. Initially with HIV, it was uncertain how it was transmitted. We all know families that I guess we acted, some people acted as if it was respiratory transmission, HIV. Thank heavens it's not. But people weren't invited over to reunions, or people physically rejected people living with HIV. So again, the sort of medical virus we don't understand that's contagious and deadly, those parallels, absolutely. And then the stigma of people living with HIV, the rejection, the judgment. I think that we all need to acknowledge that people living with COVID are experiencing some judgment. My sense is there's a subtle kind of what did you do, what did you not do? I know there's a good deal of shaming, and I would argue that there are people who we could all agree have made bad choices. 25-year-olds when bars opened up who showed up, and people who went to beaches and shouldn't have. But I think what's unfortunate is that our stigma toward people living with COVID-19, and again, there's a clear parallel to people with HIV. People with HIV, well, you should have known better, or you were a bad person, or the kind of judgment that happened when people would tell someone I'm living with HIV or are diagnosed with HIV. Some very similar negative messages to people who are living with COVID-19. And again, so not only the medical parallels, but the psychosocial parallels. Again, that's why I included that slide for long-term survivors. It's double the stigma
The one chap said, well, I don't know the gender, the person living with HIV said, I'm having a PTSD-like flashback. And I think you could argue that the issue of being diagnosed and the stigma created a traumatic event. And here I am now living with COVID as well. Bill, any other question?
Well, just one last comment about the politics of all of it. Here in Alabama, there's been a lot of discussion. I know it has been all over the nation about wearing masks. And so here in Montgomery, just last night, our city council voted to require masks. The mayor had put that into place a week or two ago, and now it's been confirmed. And I know that's also going on in Madison County in the Huntsville area. It's already going on in Jefferson and Birmingham and down in the Mobile. So our larger areas have decided, it's important to wear masks. And so you're seeing kind of a sway here. It was, let's don't tell people to wear masks, and now it's please tell people to wear masks.
Yeah. Again, I want people to have freedom. I think this America have freedom. I am also concerned about the economics of this. And so there was this push kind of beginning in early May. Let's open up. Let's stop being afraid. Let's stop wearing masks. And this wave of early states to open up: Georgia, Texas, Florida, Alabama, Arizona. That an increase in cases seemed to accompany these states that said, let's open up for economic reasons, and let's not require mask wearing. The stigma of wearing a mask, I guess I should add that to the slide. There are the viral videos of people being mandated to wear masks who are shrieking at the grocery store manager, you're just a bunch of Democrats. And it's a Democratic something, liberal something. Again, I wish we could take that out of the equation. I think for all of us as public health people to try to just sidestep that and say, this is America. We want people to be free. We want businesses to open. We want people to exercise personal freedom. But again, from the beginning of public health, where your freedom affected the public health good, to use that same vein, I'm going to say, well, this is my freedom. I'm going to not take my TB meds, and I'm going to go over to East Chase Mall or West Chase Mall, whatever the Chase Mall is over there in Montgomery. I don't feel like taking my TB meds, and this is free and free land of the free. So I'm going to go over to Belk's and breathe on everybody. We as a public health have said, no, we practice disease control measures so people aren't walking around the mall because they don't feel like taking TB. And so, we're not there yet in terms of consequences of not wearing masks. But it's just become, in my mind as a public health professional, really unfortunate that this has happened. And again, I think I'm not a politician. If ADPH wants to sponsor the politics, right or wrong, they can do that. I'm just saying from a public health perspective, it's clear. And I'm going to go on a limb as a public health professional and say it's really unfortunate that wearing a mask, practicing social distancing, staying at home, limiting business engagement has become a blue or red debate. It really is a public health matter. And the examples you give, Bill, there are hundreds of places where people adamantly said, we won't have masks here. I just read a story this morning in the Washington Post, a chap in Central California, the sheriff said, I'm not mandating masks, and that liberal Governor Newsom can't tell me what to do. He's now pleading with people, please, everybody, wear your mask because of the explosion of cases in Merced County, California. That's the reality.
Well, and the opposite of that is from an economic standpoint, you've got 8, 9, 10,000 people a day that are testing positive in some of these states. And those are 8, 9, 10,000 positives a day that are now not going to work because they're quarantined and they're at home sick. And so we're seeing just from a logistics and trying to get supplies and things like that, it's being slowed down because businesses are closing or don't have enough staff to do the work. And so it's kind of swung economically the other way.
Yeah. Well, and Bill, the only way to get the curve down is for people not be exposed to one another. And so in our rush to open up, what we found is people have had to backtrack. Texas is shutting Texas down. The governor of Texas was right there. I want everybody to open up and let's have amusement parks and let's have movies. They're absolutely moving in the other direction. And places like San Antonio, Houston, out, like Montgomery had a scare. Houston is out of ICU beds. San Antonio is out of ICU beds. And so because of that, the more regressive measures have been put back in place. And so again, yes, I want businesses to survive. I want people to be employed. But really what was shown effective, I talked earlier about other countries changing their curve. Those are countries, some of them with less social freedom, where, in China, in South Korea, you didn't get a vote. Do I feel like it or not? You were told to stay home. You did. But what we've seen is those places with more aggressive control, people didn't come out of the house until the curve was contained. That's what slowed the epidemic down in those places. And so unfortunately, what we've seen is as places have opened up, I think we could argue too early, the wrong trend. And again, I think what's going to happen, as is happening today in Texas, Florida, California, is we have this brief economic rebound that's just going to backslide, because unless we accept as a country that 50,000 Americans every day and growing is an acceptable number of new infections, I'm going to argue that it's not, and we probably are going to keep reverting back to more aggressive control measures to change the trajectory of the COVID-19 epidemic. I want to move on to some practical ways we support people living with HIV and all of us who are sexually active. Hopefully, we are all sexually active or thinking about it. Just some reminders. This is from the head of the American Sexual Health Association, ASHA, based in Research Triangle, North Carolina. Being very selective about your sexual partners. Again, think about respiratory droplets and being closer than 6 feet away. Limit new partners. Pay attention to your partner's health. The lowest sexual risk is for mutually monogamous couples. I guess you could add people that are abstaining, but if you aren't mutually monogamous or aren't abstaining, being very careful, because again, sexual contact where I'm less than 6 feet, which most intimate situations are, where there's not a mask, where there could be any risk of transmission of infectious droplets, is enormously concerning and something to be careful. Again, whether I'm symptomatic, asymptomatic, or pre-symptomatic, the potential is there. One of the things that we now know about COVID-19 that we didn't know a couple months ago was it's a real clear pattern that I can be asymptomatic and still be infectious. And so trying to think, probably 10 days, 2 weeks ago, a study out of, I want to say it's Hopkins or Harvard, one said the estimate was that for every infected American, there's 10 more that doesn't know they have COVID-19. So of the people that we know, this estimate, and again, it's an epidemiologist making, a smart epidemiologist making guess, but maybe the actual number of people living with COVID-19 is 10 times the rate of what we see. Again, today, that's 3 million Americans that we know are diagnosed with COVID. And these respiratory droplets, mucus, feces, any sexual activity where there's the potential for those fluids to come into my body has the potential to transmit. Again, for all of us, don't have sex with anybody outside of our home that we don't know has been physically distancing. We're living in a very strange time where we're making decisions about all kinds of interpersonal interaction based on how careful people have been, where they've been. In my house, what we've decided is if we know people have been smart and we're confident in their infection control practices, we are socializing, but outside only at this point. We still are not having most people, immediate family in the house, but people outside the family, we're eating out on the porch. Just, again, that extra layer of caution. So again, in terms of sexual decisions, where's this person been? What kind of precautions? If you are someone who typically is on your phone meeting people by dating apps, and there are lots of people, men, women, gay, straight, lots of people who are socialized. I'm swiping because that's what you do on Tinder. I think one of them, you swipe, who are on their phone looking for sexual partners, that it's advised to take a break. The reality of having casual sex with someone you met on the phone, you can't on your phone app. You can't possibly do any sort of screening. Unlikely you'll do any screening of that individual, and probably those encounters, casual encounters with people you've just met, are not recommended and potentially high risk. Your safest sexual partner is you. Masturbate, use toys. One recommendation, I think this slide is also from the American Sexual Health Association, a good time to find out what makes you feel good. So single people, the takeaway from this workshop might be to give yourself a chance to figure out what you like on your own until we're vaccinated, until it's safer, until you can verify. If you aren't going to stay home with your own pleasure, then monogamous relationship with someone who's physically distancing with you is the safest choice. Semi-monogamous, less monogamous, again, we're talking about harm reduction here. Sort of monogamous partner that I know has been socially distanced with me. Semi-monogamous with someone, but taking precautions, barriers, showering before and after lowers the risk. I'm not signing off. This is safer in terms of COVID-19. This is safer sex practice, trying to lower the possibility. Obviously, keeping a mask on is the single most important thing to do during a sexual encounter in terms of preventing COVID-19, and for some people, a difficult choice to make when they're in a sexual situation. Partners that sleep in the same bed are likely to infect one another. So again, depending on your situation, we certainly know there are discordant couples that one partner got COVID and one didn't. But for the most part, if you're sleeping with a person in the same bed, whether they're symptomatic or not, it's likely the partner in the same bed is going to contract COVID as well. And then someone who lives with you, who you know is physically distancing, again, that person is taking precaution. Being aware whether or not your partner is exhibiting symptoms or not, knowing your partner doesn't have symptoms is a step towards safer sexual choices around COVID. But again, there's no guarantee. And in fact, it's quite possible that an asymptomatic patient can still transmit. Limit droplets by wearing masks, not sharing sex toys, sexual positions that place faces away from one another. If you are engaging in sex, particularly without that mask barrier, not being face-to-face during intercourse is an option to lower the potential harm, to lower feces and respiratory droplets in your mouth are a high-risk way of getting COVID-19. So using barriers or avoiding sexual behavior that involves feces or respiratory droplets being ingested by me. And again, clean up after sex, your hands, your body, your genitals, being extra cautious. Hopefully good sexual hygiene anyway, but especially appropriate. So beyond sexual health, some guidance from the U.S. government on tips for people living with HIV in the age of COVID. maintaining a supply of antiviral drugs. And increasingly, the recommendation is 90-day supply. Many of us who are on medication were told early in the COVID-19 epidemic, let's go ahead and fill 90 days. And again, because of what we talked about earlier, in terms of the consequences for people that aren't virally suppressed, making sure a patient has an adequate supply, including 90-day supply. The other thing to consider is next bullet is about mail order delivery. Most important thing, and I know my HIV clinics are already on top of this, but is maintaining that supply of ARVs, including avoiding the drive up, having other, I have to go to your clinic to pick up my meds. Most places have thought about mail order, other options so that those medications are delivered. If for some reason there's a change in the ARV medication, the antiretroviral medication, it's critical that close monitoring and intensive follow-up happen. I think most clinicians would be very, very reluctant to switch medications at this point. And if by chance, as does happen, a patient reaches failure on a certain medication, best practice is to say, well, this patient seems to be faltering on drug X. I'm going to go ahead and switch, if you are in that unfortunate position, to aggressively monitor immune system functioning, to be, I think, especially mindful with that patient, teaching about COVID-19 vulnerability and COVID-19 primary prevention. And again, caution people living with HIV. Talk to your healthcare provider. Again, these are all HHS recommendations. Talk to your healthcare provider. Make sure your vaccination is up to date. I think we've been hearing a lot about perhaps another wave of COVID associated with seasonal flu this fall. I think it's a great opportunity for anybody, with all of us, but anybody with HIV to say, are all my vaccinations, including seasonal vaccinations, up to date? I'd also remind everybody that hepatitis A and B are vaccine preventable now. Bill and I talked before this workshop about hepatitis A cases still in Alabama, little outbreaks all around the country of hepatitis A, ongoing concern about particularly MSM who aren't vaccinated for hepatitis B. And so recommendations that homeless individuals be vaccinated for hepatitis A, that MSM, and people who inject drugs, men who have sex with men, people who inject drugs are vaccinated for both hepatitis A and B. And then again, to try to proactively think through what we're going to do with my clinical care while I'm staying at home. And almost all HIV clinics that I work with have gone to telemedicine. There are a number of HIPAA compliant tools, online portals that people are using. There are clinics that are open for emergency and intermittent, and particularly, I think, for patients that need unique support. But most HIV care sites, most clinical care sites have tried to triage, what do we need to see in person? What are some things we could manage? And I think most HIV care sites have said if it's routine HIV management with a well-established patient who's virally suppressed, whose psychosocial needs are stable, we're going to a telemedicine model. Again, with the idea we got to get labs drawn at some point. The last reminder from the HHS guidelines that I'd emphasize is the idea that we want people living with HIV to avoid isolation, staying in touch online, by phone, chatting. We can and should remember that being physically distant is different than socially distant. The early words, WHO made a switch from social distance to physical distance. The idea here is that we want people to be connected. And in my own life, what I find is that my day is better when I check in email, text, whatever. And I've also found that I need to see faces. And so the idea here is that video on Zoom and other platforms, Facebook, FaceTime, all of those tools to stay connected are important for all, and maybe especially important for people living with HIV. So last bit of practical advice, then I'll do a final set of questions. Keep your medications, keep your contacts available, keep contact information for your loved ones. It's time for people living with HIV, anybody living with chronic illness, to be especially mindful, to kind of be organized in a way that we might not have needed to be if hospitalized. The guidance is important around continuing medications, and a caution that if you are in a hospital, again, I'm a hospitalist, that is, I'm only treating in the hospital. I'm sort of laser focused on COVID-19 management, and I may miss the idea that your underlying cofactor includes HIV, and so I may forget to order the antiretrovirals, or it's really essential that when you show up in a hospital, God forbid, with COVID or other emergency, to say, here's the reason to have that current list of medications is to say, here's my current list of medications, and here's my doctor. Please call my doctor, my nurse, my nurse practitioner, my physician's assistant, and make sure, and having somebody advocate. This is essential because, again, if I'm a hospitalist only focused on a particular thing, and I don't have somebody who's an advocate, I don't have an organized patient who brings all their medications and encourages communication with the primary care, the potential for me to develop viral, to fall out of being virally suppressed is enormous. And again, the risk of further COVID-19 contradictions. So with that, Bill, I'm going to check in one last time. Anybody commenting or questioning?
Yeah, I've got another comment that came in. I'm hearing that the younger generation, they don't have a fear of HIV because they haven't lived in a time where it was a deadly disease. They know friends that have HIV and are positive, but they've got medications, and so there's just not a fear. And of course, we're also seeing there's not a fear of COVID oftentimes in the younger generation. Thoughts on that?
Yeah. Well, some of this is just brain development, Bill. One of the things that we know, studies on brain development now tell us that all the wiring of the adolescent brain isn't fully connected to the prefrontal cortex until somebody's 25 years old. So what we know is, and those of you sending kids off to college or got college-age kids, you better be nervous, because the prefrontal cortex is where people make well-informed, rational decisions. We say, well, should I do that thing? What are the potential consequences of doing that thing? So again, some of this is just adolescent development. Increasingly, there's another layer of this that's about brain development, just the neurology of the young adult brain and not being developed in the impact on decision making that happens. I think the other part of it, Bill, I would just name is a sort of COVID fatigue. The same way that people have HIV fatigue, we're tired of practicing safer sex, we're tired of hearing about it, and so I'm going to go out. And our messaging with HIV has been problematic. The people want to be encouraging to people living with HIV and say, this is a chronic manageable illness. This is no longer a death sentence. Again, targeting people living with HIV to instill hope. The trade-off in that messaging has been people saying, well, I guess it's not that serious. Maybe I don't need to be as concerned. And so again, the idea of just normal young adult decision-making, fatigue about HIV precautions, our messaging about HIV. And again, Bill, I think for a lot of us, I think we just need to name a kind of COVID fatigue. I'm tired of being in this house. I am tired of being in this house. I want to go out for lunch. I want to go out to the beach. I saw people taking risk with their 4th of July. I think we're all tired, and certainly those of us who are certainly adults of a certain age, know we need to be cautious. But if I'm under 40 and I feel fine, and I've heard this is a disease that's more serious for old people, whatever, I go back to the pictures of Memorial Day and people party on Memorial Day, and I think, well, of course they did. You're young, you've been cooped up in the house for 2 or 3 months, and we're tired of it, and so we take risks. There's a kind of COVID fatigue that's also fueling this challenge that I don't have an answer for, but I think is part of the problem. Bill, last call for questions.
Well, yeah, one more comment was that those that are maybe, I don't want to get in trouble with our friend Rhonda, but those that are over 50 that have some anxiety about getting out and going back and being in groups and in going to work, going to shopping, thoughts there.
Yeah.
Those that also may be HIV positive.
Yeah, no, I think you're spot on. I mean, I think that the reality as we're making rational decisions, like where have other people been, or where have I been? Do I have any underlying immune suppression? You know, I have a cousin that has rheumatoid arthritis, so there's an underlying suppressed immune system, and so I have another friend who's had a kidney transplant and is on immune compromise. So, I mean, I think we just kind of have to think through what's my vulnerability to COVID-19 and maybe take that much more serious the epidemic. So, yeah, I mean, I think the potential consequences, I'd say the current guidance is over 60. So realistically, I know I had a slide that said cases over people over 50 is concerning, but the reality, if we look at COVID morbidity, we really are talking, or I'm sorry, COVID mortality, we really are talking about people over 60. And our friend Rhonda is way, way younger than that, Bill. But so really, if you're over 60, and I'm in the club, I'm going to say it, you've got to be that much more careful, because again, if you look at rates of COVID mortality by age, 30-year-olds, X% going to survive, 40, 50, every decade, the percent of people that survive COVID goes down, and the percent of people that die from COVID at every decade go up. And so there is just increased vulnerability. So yeah, the message to people over 60, certainly the message to people with poorly managed autoimmune disorder, people with poorly managed HIV, is be extra careful because of the way COVID works and the potential negative consequences if you were infected. So,
one last comment, Jim.
Sure.
Actually, yesterday afternoon in our 4 o'clock call, we discussed the hepatitis A vaccination. It's, like I said, it's still an issue here in Alabama, something that we were working very heavily on in 2019 before COVID came around. We are still providing vaccinations at our health department, so if that's something that someone needs, they need to contact their local health department and see what they need to do about going in and getting vaccinated.
Super.
So it's still available.
Yeah.
With that said, I don't think we have any other comments at the time. So
great. Let me just say thanks, Bill. Then you can wrap up. I want to thank the Wise Woman program. We joked Rhonda Holland and her good friends in the cancer control program are sponsors of this meeting. I want to thank all my friends at ADPH. I want to thank the people living with HIV that I know and have worked with, and how much I've grown as a person. All the folks in the background, the wonderful video conference people, Brandon, Ryan, thanks to you, Bill, Darren, they're in the control room. Thanks to all of you. And most importantly, thanks to those of you that took an hour and a half to think about the needs of people living with HIV. I think it's an important population for us to be concerned about. I think there's some unique stressors, and thanks for making time, and thanks for the care that you give the people you care about. So with that, Bill, I'm going to sign out and let you do our close.
Jim, I want to echo what you just said. Certainly, we thank those that are out there watching that this is something that we are interested in very much so here at Public Health, and are glad that we were able to provide this training. With that said, this concludes our program for today. I want to thank James for being here, and I want to thank you for watching. Please remember that you can refer back to the training and resources anytime on our on-demand website. With that said, I hope you have a great day. Thank you.